I think that my task is not so easy. I know personally almost 90% of this audience, and almost everybody is familiar with natural history, HCV infection and HIV infection, but I'm trying to continue my lecture. Those are my disclosures. Our history started almost 30 years ago when we found first signs of viral particles on electron microscopy investigation. We called this virus at that time as non-anon B, currently hepatitis C virus. Currently, chronic HCV infection is a leading cause of end-stage liver disease, HCC, and liver-related deaths in Western world, so it's been in this country too. In 2006, the number of death rates, mortality rates from HCV infection and problems connected with this infection overcome the number of HIV problems. Moreover, it's much more higher than the problem with HBV infection in this country and the surrounding countries. According to data given us from the United States, the people living with chronic hepatitis B or C lived about 2 decades less than the ordinary people not infected by this virus. In the United States, HCV infection is 15th leading cause of death. Moreover, when we compare the people infected or not infected, listed diseases from other reasons of death, they lived altogether 20 years less than the normal people without this infection. So problem is very, very interesting. How is the characteristic of this virus? This virus belongs to the family of Flaviviridae, the same as virus of yellow fever, is positive sense single-stranded RNA, don't integrate in our genome, and multiplicates in a huge amount, about 10 trillion virions every day. It's a huge number of viral particles. The life cycle is known for everybody, you know, is binding to the surface, mostly the hepatocytes, in some cases in polymononuclear cells, and sometimes to the brain cells, you know, glial cells, but there's not efficient replication. It's the viral particles uncode, transform, and translocate, replicate, become a new viron. The virus is assembled, is binding, and then released from the hepatocytes to the surrounding tissue and mostly to the blood flow and infect other cells. What is the worldwide prevalence of HCV infection? We assess the number of infected persons for 180 million, but it is done according to the anti-HCV positivity. It means that not all of these people really replicate this virus. So it means that we really don't know what is the real number of infected people who are in danger to be in progress to the most serious disease, like more serious than chronic hepatitis. The centers of where are the huge amount of infected people, mostly in Africa. Here in this part of Afghanistan, it seems to be Pakistan. Here is Iraq and other countries. In Europe, we are talking about the countries around the Poland now, you know, because we are this conference in Poland, you know. The situation almost similar, except Germany, they have a little less cases and little smaller prevalence than in Poland, you know. The death rate from HCV cirrhosis is estimated about 300,000 per year, and from HCC for 200,000. In Europe, seroprevalence is low in Sweden, in Germany, except immigrants, and a little bit higher in Mediterranean countries, but it was completely different among the immigrants. We have some groups of immigrants in Poland that the infection rate, not from HCV, but HBV infection, is about 70%, you know. I don't want to mention about this group of immigrants because it could be kind of racism, you know. So we don't want to exclude this patient from our society. Poland. In 2013, the seroprevalence was assessed between 0.9 to the 1.4, but only less than 40% from this patient really replicate this virus. It means that in our country, is a country about 39, 40 millions on inhibitors, 10 millions outside Poland, you know, we have about 200,000 people really infected by this virus. Among them, there is 30,000 women in procreation age, so this group can transmit, we can influence this process to the children. And theoretically, only 30% of these patients have progressive disease and should be treated. It's mean 75,000 people in this country. It is a huge number of people according to the prices of drug listed to the therapy of this. The incidence is decreasing. In last current data, it's 5.88 in 2013. This virus is very complicated. We have different genotypes, for sure 6, probably 7, more than 50 subgenotypes, isolates, and quasi-species. In Western Europe, in the United States, dominate genotype 1, B, 2, and 3. In Eastern Europe, 1B. In North Africa, 4. In Taiwan, number 2, and Hong Kong, 6. All the genotype, of course, we have in Poland. But what are the differences? In our country, predominates the genotype 1B. 1A is very rare. Genotype 2 is extremely rare, 1 per 100, you know. And others, there are genotype 3A. But there are differences between east and west part of Poland, you know. In part of Poland where I'm living, it is the western part of Poland, predominate genotype 1B. In eastern part of the Poland, close to the Russian-Lithuanian border, predominate genotype 3. There are specific differences. We don't know why. But each genotype is actually a mixture of closely related viruses called quasi-species. We have a lot of viruses, so these quasi-species have the ability to mutate very quickly and become immune to current treatments, which explains why chronic hepatitis C infection is so difficult to treat and why the chronic infection progress to the more advanced stages. How is the distribution of genotype? It's very various, you know, but our distribution of genotypes is similar to the Lithuanian problems and to the Belgian problems. To the Lithuanian, we understand why, because we had historically almost similar countries, you know, but to the Belgian problems, I really don't know, except, of course, immigrants. Risk factors. What are the risk factors? There are problems known for everybody on this audience. Current or former injection drug users, including to injection only once, many, many years ago. Recipients of clotting factors before when produced the properly produced this clotting factors, it was in late 80s, last century. Recipient of blood transfusion sold in organs before July 92, sorry. Chronic hemodialysis patient, person with known exposure to HCV, like healthcare workers after needle stick exposures, recipient of blood or organs from the donor who were tested, who was tested HCV positive, body piercing, scarring, tattooing, and thousands of such behaviors. But the HCV is not so contagious as other viruses, much more higher contagious than HIV. There's a conference about these two viruses, less contagious than, not infection, less contagious than the HBV virus. Moreover, the person living with HIV infection, children born to HCV positive mothers, intranasal cocaine users, this growing problem in Poland, sex with multiple partners, particularly among the people who prefer anal sex. In last 2 years ago, it was published a very interesting paper in Journal of Infectious Disease about the other risk factors. The young authors from the United States assessed the living particles of HCV among the dry droplets of blood. Previously, we assessed the risk as almost none, you know, when we have a contact with dry droplets of blood. If they kept the dry droplets in various temperatures, they found that the living particles persist to the 6 weeks after the start of the experience. So it means that for many of our patients, without evident signs of exposure, there is a risk to be infected with the contact of not properly cleaned surfaces in the hospital, especially immunocompromised patients. How is the natural progress of the disease in Poland among the 40% of our people, At the beginning, we had acute phase. Acute phase, it's been clinically significant or not. This, in 60% or 40%, it depends on the country and statistic, progress to the chronic liver problems, chronic hepatitis. Some become asymptomatic carrier, some eliminate spontaneous HCV. Very rarely we observe acute liver insufficiency. Probably not observed in Poland for many years. This is a problem for Japan, China, and Taiwan. Altogether, we can observe at the beginning extrahepatic manifestation, but this extrahepatic manifestation can't be observed during all phases of this disease. 30 to 20 patients from chronic hepatitis progress to liver cirrhosis. From this group of patients, we have they progress to the HCC or liver insufficiency. The end of this natural history is the death of liver transplant. But if the patient is not properly cured before the transplantation, situation repeats once more. We started this natural progress at the beginning once more. Of course, there are other influences to influence this natural history. You observe another clinical manifestation, for example, fibrosing cholestatic hepatitis, not observed at the natural course of this infection. What are the clinical extrahepatic manifestations? Typical: hematological, dermatological, renal, endocrine, salivary, ocular, vascular, neuromuscular, autoimmune phenomena. There is a very complicated problem, this autoimmune phenomena. We really don't know if we have overlap syndrome, autoimmune disease, and HCV, or HCV and some effects for stimulation of the immune system. It influenced our approach to the therapy. HCV infection basic facts. The transition from acute to chronic hepatitis is usually subclinical. I have on my ward every year, there's about 1,000 to 500 patients every year, 400, 500 patients infected by HCV. Among them, only 3 or 2 are with acute hepatitis. Only, no more. The acute illness is clinically mild and is typically unrecognized and undiagnosed. Risk of chronicity is variable. The natural history of chronic hepatitis remains incompletely defined. Especially immune response is completely different in acute phase and chronic phase. Generally, it is slowly progressive disease. But among some group of people is rather progressive, very fast progressive disease. We know why, but of course there are a lot of cofactors. Risk of cirrhosis is without cofactors is about 20 to 30% within 30 years from the infection. Cirrhosis-related mortality 5% per year. Incidence of HCC in patients with HCV cirrhosis is about 1 to 4 per year. Moreover, the effects of chronic HCV infection extend beyond the liver-related mortality and decrease the quality of the life as other viruses, HIV, HBV infection, and so on. Clinical picture is influenced by host, viral, and environmental factors. The environmental factors are not particular in details now, but host and viral are known. What are the typical viral factors influencing accelerating progression of HCV? Genotype, pseudotypes, mutants, level of application, immune response, various immunosuppression. And the factors from our side as a human being. Route of transmission, much more efficient intravenously than other routes. Infectious viral load at the beginning, acute phase or not. With patient with acute phase, very commonly, typically eliminate more often virus than the patient without asymptomatic at the beginning. Gender, as always, the female are much less susceptible to the chronic manifestation than the men. We really don't know why. Maybe there's some kind of influence of alcohol. Race, black one to white one. BMI, insulin resistance, and cofactors. The cofactor, HIV infection, is a cofactor which influences the clinical picture of this infection. HBV infection. What about herpes infections? The problem is not unsolved, is unsolved till now. Acute hepatitis. Generally, it's completely asymptomatic disease. The symptoms develop generally after 1 month of the infection. If they are clinically significant, we observe typical signs of acute hepatitis. But acute resolution HCV is not associated with any long-term sequelae. It means that patients, after the elimination of virus, become healthy as, for example, HCV infection. It's the same. There's a problem, what we assess as acute infection. The world annual incident indicate that every year 4 million people are newly infected each year. The CDC estimates approximately in the United States that every year 30,000 of American people are infected by HCV infection, by HCV virus, you know, adjusting to the asymptomatic. The number of acute cases in the United States, there's there are various populations, black, whites, Chicanos, Mexican, Latinos, and so on. They assess for 1 to 1,000. It's a growing number of this patient with acute hepatitis. So what are the other cases of acute hepatitis? Almost asymptomatic. All the patients without jaundice are not recognized by us as having acute hepatitis. Probably yes. Reinfection. The patient could be cured, for sure, can spontaneously eliminate this virus, but that can be reinfected. We have such cases. There are mostly men who have sex with other men and intravenous drug users. How we confirm? Because we found another genotype in serum, you know, so it's a real confirmation of reinfection of superinfection. Chronic hepatitis. If HCV RNA persists more than 6 months, we assess the patient being a chronic. Chronic from infectious point of view, not chronic from the liver disease. Some of them have a chronic liver disease who can progress or not. Spontaneous resolution of chronic hepatitis C is relatively rare, but occur about 0.5 per year. So it's happened without treatment. But what influenced the progression to the fibrosis, what is especially dangerous, would create, of course, this main event of cirrhosis, advanced cirrhosis. The age of infection and cofactors. When we are infected at the childhood, the progression is about 30 years to the advanced disease in some people. When we are infected after 50 years of our life, the progression is very, very, very quick. About 10 years, 5 years, to the real advanced liver disease. Liver cirrhosis. Liver cirrhosis is another clinical picture of the same infection. From epidemiological point of view, HCV is infection, is contagious in infectious disease. But cirrhosis is most advanced, most dangerous, very complicated, with wide range of symptoms, signs, and consequences entirety. Moreover, some years ago, we broke the dogma that in the liver, we observe the same stage of the disease. We use a needle, for example, we perform biopsy. It's a chronic hepatitis, cirrhosis, not. If you observe these explanted cases, you can see here the cirrhosis, here ACC, completely different stage of the disease, and this part is a chronic inflammation. Of course, I know that the biopsy taker from is to take this biopsy from this part is impossible to perform, but it's happened. There are 3 different stages of the disease, so we broke this dogma. What are the other stages of the disease? Look at that. There's a typical cirrhosis with ACC. This is a typical cirrhosis, almost cirrhosis with adenoma. It's not HCC. There are cirrhosis with ascites and HCC. So completely different stages. Moreover, there are signs of second most important sequelae, portal hypertension. There are varices, alligate personalitis varices. Moreover, on the surface, you can see the white changes. There are candidiasis of the esophagus, typical changes for one's AIDS, but there's a cirrhosis without a co-infection of HIV. It means that the immune response, immune system is deteriorated. There are immunocompromised patients from others' point of view. There is a next one, complication. There are gastroventricular varices, and the consequences, real hemorrhage from the varices. Moreover, the clinical picture of HCV cirrhosis is complicated. We have stages of this disease. No varices, no stasis, probability of death is only 1%. When we have varices bleeding in past history, on current history, with ascites, the risk of death is in 1 year is 57% or 60%. So more than half patient died in near year. HCC. Chronic HCV infection in our world, in our Western world, is leading cause of hepatocellular carcinoma. But RNA genome is not observed in the HCC cells, except some specific cells. But 90% of patients, HCC, infected with HCV and cirrhosis, have other cofactors, like alcohol consumption in past history and current history, aflatoxin contact, that's many nuts contaminated, non-alcoholic hepatitis, growing problem everywhere. We are staying bigger, fatter, we eat more, we participate in many conferences, there are banquets, drinking, and so on and so on. Moreover, congenital metabolic disturbance. How we change natural history of chronic HCV infection? Can we change or not? Yes. The milestones of success are early diagnosis and proper treatment. There are next lectures about the proper treatment and only 3 slides about this problem. We should start the therapy at the beginning. We can easily treat the patient with acute hepatitis only with interferon. The success rate is about 60 to 90%. But not is reimbursed. We don't know why this problem is not reimbursed in Poland. There are a small number of patients diagnosed every year with acute hepatitis, but we can treat this patient, probably in many countries, other countries too. What are the results of the treatment with other methods of therapy, for example, 3P therapy or I-free therapy? The results of I-free therapy for this group patient are not published till now. With old-fashioned drug like telaprevir, peginterferon, ribavirin, there's effective therapy, better one than only interferon, but we can't have this, we can't treat this patient. Resolution of HCV is not associated with any long-term sequela, so the patient become healthy. Chronic hepatitis. There is a revolution in our treatment, will be presented you by Dr. Tuboti in next lecture, We can use triple therapies with new DAA or I-free therapy with rate success about 100% for any of currently discovered genotypes. Achievement of SVR is not in a stage of HCV-related diseases, change natural history of this infection. Reduce, but not fully eliminate progression of liver cirrhosis, risk of RCC, and lowers liver-related mortality. Thank you for your attention.